This is the One Thing Podcast, and I'm your host, Dr. Adam Rindy. The One Thing Podcast brings together leaders in functional and naturopathic medicine to discuss actionable information that may unlock puzzles in the areas of gut health, brain health, metabolism, and longevity. Please note, these episodes do not replace the opinion of your doctor. They are not intended to diagnose or treat any condition. Please discuss this information with your provider and discuss your own unique personal health history before adapting this information. Please subscribe to our episodes so that you can stay on top of the most current information in these areas of medicine. Mycotoxin and mold illness is finally getting the attention it deserves. This is taking place mainly in naturopathic and functional medicine circles, and the condition is still largely overlooked within conventional medicine. Today I bring back Dr. Lauren Tessier, who was with us previously to speak about mycotoxin and mold illness. She's a worldwide expert in mold and mycotoxin illness, and also is the president of the International Society of Environmental Acquired Illness, ISEAI. And she's going to speak with us today about the reason mycotoxin illness is on the rise, testing pearls and testing limitations. We go into how this condition is a neuro-immune-endocrine disorder. We speak about organic foods and how they might be a route of mycotoxin exposure. We talk about detoxifying mycotoxins and binders. There's a special offer for the listeners of this podcast. Please see the show notes below. Dr. Tessier has offered a discount code to our upcoming conference on May 19th, 2022. This is the ISEAI conference. So see below for more details on that. So without further ado, welcome to the next episode of the One Thing Podcast. Dr. Tessier, welcome back to the One Thing Podcast. It's great to have you back with us again.
Yeah, it's great to be here. Thank you for having me back.
Yeah, it's we were speaking last in April 1 of 2020 was around the time that we connected. So there was just a little bit going on back then. And yeah. So what has the last couple of years been like for you in general?
Yeah, I think the last couple of years, I think have brought a lot of things into perspective in general. I think we've all, from, a personal and professional experience, have really just really brought back to task of what is important and kind of what is the bare minimum needed for happiness, and how everything else is outside of that a lot of times. So, there's been, I would have to say that's probably some of the bigger things that have happened. What do you get by with, and how do you keep happiness in your soul and a sense of calmness when things are chaotic, both personally and professionally?
Yes, all good things. And, the also the amount of time that people have spent in their homes, right, has dramatically increased. So I imagine that's influenced your work a little bit.
Yeah. And, it's also more time at home, but also less time in the office and less time at school. And so it's just this idea that people have had this noticeable, like mold avoidance thing, like when we send people to the desert to get out of mold to see how their symptoms improve. We had that forced upon all of us. Some people got worse, some people got better.
True.
So very, very interesting.
Good point. Yeah, I think a lot of people just assume that the exposure's in the home, And no, it could be car, school, workplace. So yeah, that's a good point. Depending on what environment they moved from to a more healthy environment or an environment that was more possibly mold exposed or mold burdened. So I'd love to hear some of the kind of wins that you've been experiencing in your work as a mold illness expert. So I know you're involved with some nonprofit work, and maybe we can kind of start up hearing some updates there.
Sure. So I'm very thankful that for 2022, ICI is going to actually be having an in-person conference in Denver, Colorado. It's been, a really big leap of faith, to kind of go out on this limb, because the last meeting we had was virtual, and it was in 2020 and in the fall, and it was great. It was wonderful, but we're just trying to get back to that magic and that tangible physical community that we had with our breakout conference in 2019. So, we're really excited about a lot of the different folks who are going to be speaking, and we're going to have a lot of information about CCI and neuroinflammation and kind of how that intersects with mold. And of course, we have like the mold basics and the pre-conference stuff. So that has to be a really big win. And
yeah, when is that?
That is going to be May 18th to the 22nd.
Wow.
Denver, Colorado. Yep. And people can find out more info on that at iseai.org.
Great.
Yeah.
Yeah, that's exciting. Congratulations.
Yeah. We're very, very excited about that. And hopefully we have some big news to share with folks about kind of picking up on a big project that we have for our members that was put on pause once the pandemic hit. So hopefully by the time this gets released, there'll be a little bit more of a trickling out, and people will be able to put two and two together for us.
Yeah. Well, I have certainly noticed that mold illness is a big buzz these days. So you guys are doing a great job of getting the awareness out, whether that's coming from all the people involved or just because this is more pervasive or it's more on their radar. But I certainly am seeing more patients informed and more practitioners informed. And it's really climbed over the last 2 or 3 years. Any comments on that?
Yeah. There's a lot of reasons. There can be like the good reasons why it's growing in awareness, and there can be the problematic reasons. So, maybe just biting off the initial problem piece is talking about maybe some of the more problematic reasons why we're seeing it come to the forefront. We do have changing climate patterns. Places that were once dry and arid are seeing more water issues, and their construction isn't capable of standing up to those more humid, damp changes. So we have this climate shift. On top of that, we're also having a potential expansion of antifungal resistance growing. And that's not just from, our medical paradigm, but also in our agricultural and also our construction industry. Mm-hmm. All of those use azole, triazole class of drugs, compounds, and you start to see people who are medically naive to the azole and triazole class of drugs have resistance to different fungi that should be susceptible to these class of drugs. And we're raising a weary eye to the fact that, we use micronized copper azoles on our pressure-treated lumber. We spray azoles all over our food to try to fight back like fusarium wilt or things along those lines. So I think that there's a bigger resistance pattern that we're seeing that's also bringing a lot of stuff to, the forefront.
Yeah, so people don't realize that. I mean, I know of categories of foods like grains grain production uses a lot of antifungal treatments. Is there other categories that we're not as much aware about?
I think that there might be some for non-grains. I would have to get more clear about that. But also keeping in mind, we're feeding these grains to our livestock.
Right.
And then we're getting potential bioaccumulation or, inoculation of these livestock with, resistant antifungal. So, or a resistant fungus. So, that's some of the more problematic reasons of why it might be growing in awareness. Maybe some of the more beneficial reasons is just that more and more people are starting to put the pieces of complex chronic illness together with this resistance to treatment. Why are people not getting better, but why are they also getting sick in the first place? And so I think a global movement from, the allopathic Western traditional medicine, which has a time and place, towards a bigger awareness of functional medicine and naturopathic medicine. I think that that's really driving that home. And I really hope in my heart of hearts that we see that sea change that happened for Lyme happen for mold too.
Yeah. You said the word drive, and I love that because I think the aspect of looking for disease drivers is sort of what we've really seen blossom, and putting mold illness in that category of what's driving this chronic illness, and to have that on the dashboard of things that we look at has really surfaced.
Yeah. And it's that idea, and it's the naturopathic history of, what exposures are causing the chaos in the body. And it's nothing new.
Right.
Naturopaths have been dialoguing about this for so long, but, now it has a term like the exposome and the interfaces that, the body and, it's really inspiring to see more people try to dig deeper and see what's going on.
Exactly.
On
the flip side, and we'll get into this in a little bit, is that it still is not acknowledged in many circles. So I'll kind of circle back to that and talk with you about that in a bit here. To last time you were on one of our most well listened and downloaded podcasts, and I must have sent hundreds of my patients to this link by now, where you talked so eloquently about sort of a framework of thinking about mold-related illness. We talked in that episode about sort of these 4 categories of mold illness and how there is some interlap from the standpoint of fungal infection, mycotoxicosis, fungal allergy, and also CIRS. Has anything changed in that kind of Venn diagram as you talked about?
I would say no. And if anything, I've doubled down on simplifying it even a little bit more for people. Every now and then I have someone slide into my DMs and it's like, well, what about cancer? What about mold and cancer? And it's like, well, yes, absolutely. Aflatoxin gets processed by the liver to problematic intermediates, and you're having the toxin cause the immune system chaos that's leading to the, so the way I found is classifying it doesn't really change for me, but, there's always these kind of funky things that people come up with, and I somehow managed to get them into one of those 4 circles, at least in what makes sense to, my mental paradigm of it.
Sure, that makes sense. And then also we talked about how one of the unique aspects of mycotoxicosis and along with CIRS is that it's a neuroendocrine disorder, meaning these mycotoxins have an affinity for the nervous tissue. And I think that really gives a way to start the process of thinking about how it might manifest in someone's health and symptoms we might see. Does that still kind of fit with your framework?
I mean, 110%. If even more so now, like if people can just stop and take a beat and think about the concept of lipid solubility, like dissolves like fat in fat, that is where the rubber meets the road with mycotoxins. And so anything in your body that interacts with fat and lipids or that non-polar substance, that's going to be drastically impacted. And where do we find those things? In the liver, the nervous system, the endocrine system. Yeah, I would definitely say that's doubled down even more so now.
Okay, good. And, the other, when you talked about CIRS, which is more of like a systemic immune response to a number of things, but mold is thrown in the mix. I was curious whether we could call that a dysautonomia process, because it seems like when you talked about that process, it just really affected so many aspects of the immune system, the endocrine system, the nervous system, and then you start to see dysregulation of the autonomic nervous system in those settings. Can we consider CIRS like in the dysautonomia category?
I mean, I certainly would. We see dysautonomia like symptoms anyway in CIRS, So, I mean, yeah, the dysautonomia, if people think about the 4 overlapping circles of the Venn diagram in there, I would more lump the dysautonomia as a symptom kind of hanging out between mycotoxicosis and CIRS. The fact that it can exist in both, because it's some abnormal functioning of the immune system that could potentially be due to a neurotoxic element.
Yeah, great. Well, good. Well, I'd love to kind of jump into some other topics, and I kind of want to circle back, like we said before, is we're still in this place where even though the awareness is increasing and unfortunately the incidence is increasing, there's a lack of acknowledgement of mold illness. And I personally have experienced it. I have referred people to some of the most esteemed infectious disease doctors in this community, and they just kind of shrug their shoulders and say, I don't think this is a thing. And there's others that are coming around, of course. This is sort of like a one-off situation in my community, but I still hear it kind of, patients are afraid to bring it up to certain doctors. They think that they'll think they're crazy for bringing it up. They'll think they'll just kind of like never trust the patient again. What's going on in that space, and why is it still kind of half hanging over its head?
Yeah, so I'll start kind of with a question of thinking back to your education when you went through, your naturopathic doctorate. Do you remember having any lengthy dialogue about mold?
First of all, that was a long time ago. So let me think back. Yes, I do.
Okay.
I do remember Dr. John Hibbs, who we love so dearly, bringing up this topic to me and on his environmental illness clinical rotations.
And so in the so I also had Dr. Hibbs. I was on his shift. He was absolutely wonderful. I think that there's a limitation, though, of what could actually be discussed in that context, right? Like we can talk about the different forms of mercury in the environment, or persistent chemicals that are kicking around. But my experience, at least when it came to mold, was kind of stuck in with the sick building syndrome, maybe a lecture and a half kind of about the bigger global stuff, but not kind of getting into the nitty gritty of what a lot of the issues with mold and mycotoxins were. Maybe I have a horrible memory and I didn't show up that day. um, but, I unfortunately, and it's not a reflection on our teachers, it's really a reflection on what is in the data. And so, I've spent tons of time researching and learning and hundreds of hours. And unfortunately, there's not hundreds of hours in the basic education that are provided to naturopaths, DOs, MDs alike. To kind of take a step further, the bulk of our education in all of our programs is really based off of some type of peer review science. There's mostly stuff in the literature that we're calling from to teach these new doctors. And there is not a lot in the medical literature about mycotoxicosis, about CIRS. However, there's a plethora of information about allergy and fungal infection to a smaller extent. Mm-hmm. However, allergy and infection are words that are just like synonymous with Western medicine. However, even that toxic element of mycotoxicosis, less so. So the issue with the lack of literature results in a lack of representation in the educational systems. Now, if someone goes into, PubMed, that's what I mean when I say literature, and you go digging, if you go into the agricultural industry and you go into the veterinarian medicine and kind of animal studies and that kind of stuff, you'll find tons of information about the impact of mycotoxins on health. Mm-hmm. But because of the limitations of the way institutional review boards run, we can't knowingly expose a human to something that's going to cause detriment. So we have all this great literature on animals, and we have a limited amount of literature on humans. But what we do have are these longitudinal, like cohort analysis that are retrospective. These people happen to be exposed. And so it's not the type of literature that a lot of people set their educational standards by. It's not the randomized placebo-controlled trials of XYZ. So there's a lot of problems with the lack of literature. Now, when we have a lack of literature, it kind of is this Ouroboros of lack of research funding. Mm-hmm. And then from there, when we don't have something really acknowledged vociferously in the literature, then we don't have diagnosis codes.
Right.
And we don't have diagnosis codes in any of our ICD-10, ICD-11.
Can't get paid.
They can't get paid. Physicians can't get paid. Patients don't have representation at all. And then it comes back to no one's researching treatments and no one's researching testing. And so it's this really crummy, just feed forward mechanism of the bias in literature and the lack of the evidence that's the gold standard. And what just drives me so nuts about this is the literature that we have about this stuff is in the same animals that we test all our chemotherapeutic agents on. It's in the same animals that we test all our, biochemical theories on. So I don't understand how we can have the cake and eat it too and say that literature is trash. However, the bulk of Western medicine is built on the backs of these types of study participants. So I get really fired up about this. And if you look at what is actually available to people with diagnosis codes, you have mycotoxin poisoning, intentional or unintentional, from food. It infers food consumption, and that is it. Mm-hmm. It's just such a huge smack in the face. But that diagnosis code goes hand in hand with what we see in their agricultural literature, mm-hmm. And what we see with the assessment of food systems around the world. Those are representative of the data that we have. So, I just want to see more data of people showing up to just clinical data, but I don't know if that's enough to get an ICD-11 code in place for this stuff.
Yeah. And what drives me crazy, and maybe it's more of a great place to have a conversation starter with a doctor, is we know that mycotoxins and mold products kill stuff, right? So like CellCept is a mycotoxin-ish kind of drug, isn't it? That's one of these drugs that if you take a mycotoxin test, the derivative of CellCept seems to show up, either if you're taking the medication or if you've been exposed to it naturally. But also penicillin, right, comes from the mold world. And of course, like Candida albicans has been, it's a fungi, and some of the products of Candida have been studied. So there is like 3 really well-known medications or environmental components that are good conversation starters, at least, would you say?
Yeah, I think that, there's a middle road for everything, right? There's always a gray area. And we have a lot of medications, even antifungals, that are sourced from molds. We have a lot of the citric acid out there is sourced from molds. Like, I think if you throw the baby out with the bathwater, people, I think, it has that orthorexic paradigm that comes with all things mold and, all things fungus. And the reality is, like, we have good bacteria, we have bad bacteria, we have good fungus, we have bad fungus. So I think it's a nice shoe-in to at least try to take the nervous system stress response down a notch, so that the threat level isn't there when you dialogue with people about it.
Yeah. So that's a really good point, and I think it's always good to connect with the balance perspective of our environment, and how it's not about sort of shifting it one way or the other. It's just about kind of how does our body and our physiology work with what we're exposed to, because you can't avoid mold. It's impossible.
No, and it's in our biofilms. It's everywhere in our biofilms. It's in our oral biofilm. It's in our gut biofilm. And that's why I get, there are certain tests that look for like fungal metabolites, and I don't use those as much, because you have tons of candida in your mouth. You have vaginal candida. You have, I think there's even cladosporium. I remember putting a lecture together for last year at ICI. There's cladosporium in some of the biofilm throughout the body. Like it's there. The problem is when it gets out of check, or it challenges the immune system, or it starts secreting too many toxins, So I don't know personally how to really thoroughly use those fungal metabolite tests that sometimes you see with organic acids tests. They haven't been part of my integration into my practice. However, when they pass my desk, I go, oh, that's interesting. Because right now, I don't know if I could draw it on you, and just because of your baseline of candida in your body, that you might have, an elevation there.
Okay. Yeah, I can see that. So speaking of testing, you more focus on those tests that are just looking directly at known mycotoxins.
Yeah. As a starting point, right? And within the context of what is someone's current exposures and or historical exposure. I know the limitations of the mycotoxin testing, especially where they're urine. You're talking excretion, you're talking one point in time. So I use them more as a screening tool initially. And then where I find my clinical utility really lies with those is using them as a data set and watching overall trending. I don't worry about the one-offs. I want to know what happens at month 0, month 3, month 6, month 9 to see what the downtrending and the changing, what that looks like,
Mm-hmm.
clinically speaking. Can you sometimes not tell the difference between someone unburdening their storage versus a food exposure? Sure, I'll be the first to admit that. But again, I'm looking at global downtrending. That's why I would never suggest someone to order these tests every 2 weeks or anything like that with clients. But what I've seen clinically, and again, I don't have the data to back this up. I can only share what I've experienced. When folks have really huge increases in their urine mycotoxin test, I'm talking about 10-fold, 13-fold, 20-fold, and it's out of the blue. Their diet hasn't changed. Usually, if you go digging a little bit, you can uncover an exposure or something. Oh yeah, I did have a new water intrusion event in my house, or, I started going back to, that old church again and in the basement for Bible study or something. So what I've at least found in the context of what we can tell from urine mycotoxin testing is that at least these huge giant spikes are typically not from inducing your detox pathways. I seem to be able to correlate it to a gross re-exposure for people.
Well, that's good to know, because there's varied opinions about that, or at least that early on in my training, I learned the opposite of that, possibly that if there's a spike, it's like you're clearing it finally. But that's really good to know and to keep that in perspective.
And again, it's not just a spike. I'm talking about someone came in with like a trichothecene of like 0.5 and suddenly they're registering like 8 or
like a 10. Scale. Yeah.
Right. Because what will happen, you will see the urine spikes. That's what we expect on follow-up at 3 months, 6 months. You expect it to increase because it's leaving the body. But at that point, you'll start to see and again, this is just from all of the clients I've seen and the data I've gone through, you'll tend to see like a 2-fold or a 3-fold. It never seems to be the ginormous 10-fold. So that, that's just something that I have learned from my clinical experience. Your mileage may vary, and I also invite people to realize if someone starts eating more rice, or if someone starts eating more corn or wheat, that's where you got to raise your eyebrows. If someone starts eating more meat that's grain fed, you have to raise your eyebrows. But that's why when I work with people, we make sure the home is clear. We make sure that their diet is not changing. And so with those two things being the biggest exposomes, the route of entry into the body, when we see huge, ginormous spikes that aren't really, that are just fantastically elevated and abnormal, that's when I start to think about the home again for people.
Interesting. And I just want to kind of poke my head in on that response a little bit more. I've heard recently and read some things about like organic produce and organic foods actually being a route of exposure for this issue.
Yeah. There's some data floating around that. Oh, this kills me. Organic baby food.
Oof.
Organic baby food, right? Because you're not using the antifungals on the food, is having higher amounts of mycotoxins in the food. And I step back at some point and I'm like, maybe I want to give my baby conventional food.
Yeah.
It's the risk benefit ratio, which is something, you always spoke about. Is that going to be having that antifungal component passed on to you, or is it going to be having the neurotoxic component?
Right.
At this point, I much rather have an azole kicking around in my system than trichothecenes. Trichothecenes have been studied to be a potential biological weapon. Azoles, not so much.
Yeah. And, with ZA, also, which is an endocrine disruptor, right?
Yeah.
So it is concerning. And it's like sometimes you're just kind of like, oh, we can't win. Like, we're eating all this organic food. We're trying to raise our kids right. And it's like, okay, this is an issue. So I do like to frame that. And one of the things that you most artfully said in our first conversation is how you actually really focus on detoxification pathways as a foundation. And, that's really the end all be all of kind of what we're talking about. Is you could be someone who's just has like an Olympics style detoxification system and spend some time in a swamp and walk away okay. Some people have genetics that make their detox more slower or deficient. Could you talk about and revisit that? Because I just thought that was such a great lesson, is how important detoxification is and how that's kind of where you start.
Yeah. So, I think of, as anyone in environmental medicine would, that toxifying a system is going to cause absolute chaos with any of the functionings. Anytime people see a resistant case, think of what the possible toxic component could be. And in that 1%, maybe it's mold, or maybe it's mercury for the other percent of people, whatever. But thinking about the toxic component, and the body has these innate systems, like body heal thyself. It's not pumping detox, mass action, law of mass action, A plus B equals C, push the detox. I don't do that with my clients. And if I do, I'm doing tons of prep work. But just keeping in mind, everyone has different detox pathways, different genetics for their different detox pathways. And I have people think about The Price is Right, the Plinko game, where they have the little chips that go down and they bounce around. And I tell people, like, each one of those little channels can be thought of as your CYP pathways in your phase 1, 2, your phase 1, phase 2 detox. And each one of those pathways can get clogged up with something else. It's the reason why you don't pair oral contraceptives with antibiotics. It's why you're careful with St. John's wort and some of the HIV drugs. It's why grapefruit and statins. So you have things that can modify or can induce or slow down some of the detox pathways. And to kind of turn this into a little bit of an Ouroboros, we can have mycotoxins that block other mycotoxins going down those detox channels. So when you sit down and you look at someone, you're like, okay, well, what's happening with your genetics? What is happening with your family history genetics? What is happening with your sex-linked genetics? Because there is a difference in the mycotoxin literature, which is a total trip. Men and women will detox DON, which is also known as vomitoxin, totally different, even though they'll have similar exposures. So we think about, what's happening with your internal genetics, both from family history and sex. What's happening with your food exposure? So much to say, what's modifying your detox pathway. So I have people just stop and think about nature, nurture. What's going into your body that's messing with your detox pathways? What are you already given by just you being you that is slowing down or interfering with some of these detox pathways?
Great. And have we learned anything new about binders lately?
I'm a little bit, I wouldn't say pessimistic with binders, more of a keep it simple, stupid. I like charcoal. It saves clients money. I've seen it hit all the mycotoxins for all clients. And I think that people with a binder, with any type of binder, are going to have some type of benefit. The question is the binder a surface area binder? Is the binder positive charge bile acid sequestrant binder. There's all different mechanisms of action for binders. There's like modified citrus pectin, which actually crosses into the bloodstream, supposedly, and acts as a binder. So, you can even go as far as like a IgG oral as a gastrointestinal binder.
Right.
But you can spend so much money on the IgG. You can spend so much money on the modified citrus pectin. And meanwhile, I can have someone, use charcoal pretty easily and get some good traction. Can there be a time and a place for bringing on clays or paying through the nose for compounded bile acid sequestrant? Sure. But I've fallen more in love with charcoal over the years. And yeah,
I was talking about this with someone, how, when you first start out in practice and you leave the confines of the, the halls of education, you sort of get into like lots of this complex stuff. And then the more years you practice, you're like, wait, it was there all along and it was simple. And you start to kind of like say, some of these foundational things are really solid and it wasn't just kind of old news. So I don't know if you've experienced that. I'm certainly experiencing that. Like I hear myself saying things now that my professor said, 18, 20 years ago. And I thought, that's outdated.
One of the things that used to drive me crazy going through our education was, well, why do you want to draw that test? How is it going to change treatment rationale? And I'm like, because I want to know if the person has a gluten sensitivity. And they're like, yeah. And how is it going to change treatment rationale? And
right.
I don't know, because I want to know. And now the dialogue truly comes with my clients where it's like, hey, I can treat you presumptively. We might not know when to put down one hat and pick up another hat, but we can get some traction with it. Or if we order this test, we can find out this, and this. It's not necessarily going to change my treatment rationale. So, we can use it just out of curiosity. And some people want that data set. Some people say, I have a partner who doesn't believe me. I need proof, or I'm potentially going into litigation or something, so
exactly.
It's so odd to come to the point where I find these things coming out of my mouth and I'm like, oh gosh, I know exactly who I sound like and in what context. And I think patients also appreciate that too. Every now and then you're going to have a data-driven like biohacker patient who wants to know it all. And at that point, you can really enjoy like geeking out with them, right? Like, let's order this and let's see what the deal is with that. But just simplifying and streamlining as much as possible. I think that I think the place for minutia and myopic insights is in the building of the theory and the creation of the protocol and putting pieces together. And then I think it's reasonable to like pan out and see what potentially falls away,
Very nice. It's kind of like how I would imagine an iPhone was designed. It's like all of a sudden the end product is a very streamlined, simple device, versus like all the buttons you could have. So the one thing I do want to point out now that we're kind of on the topic of our kind of professors and influences is like Bill Mitchell used to always talk about how, we're treating the cause and we're trying to like help people get better, but we also can help them feel better, early on. Mm-hmm. And I think you do that really well. In fact, when I was living in a mycotoxin, when I was living in a mold infested home a while ago, you told me about citicoline, and that was such a game changer for me to help my brain get back online. I've since moved and it's like night and day, but like my brain, I recognize myself again. But like, I think it's really important for people to know that while they're doing this foundational hard work, there are tools out there that can kind of get you feeling back online enough so that you can actually accomplish this this big task of healing.
Yeah. And with naturopathic medicine, if there's one thing that I can tell people from firsthand experience, and it's because I learned the hard way. There's no dogmatism in medicine, and puritanical approaches to medicine. It's just, you're gonna just circle the drain on this glory of perfection, and you're gonna miss out on being able to best serve people or make some good changes while you're busy chasing that, just while you're busy chasing that, the concept of like that pure life that naturopathic medicine puts out there. It's like,
right.
I tell people some of my interventions, like, if you need ibuprofen, take ibuprofen. If you need something palliative, do it. And it's even to the point that palliation has become, I feel like during my training, potentially in some settings, it was a 4-letter word. And now it's like, I sometimes can't touch people when it comes to treatment until there is palliation on there. Yep. That's the whole concept of treating mast cell activation stuff before you start detox. Like, I'm putting someone on an H1, an H2, like codofen and like all that kind of stuff. And that's not very naturopathic of you, Can't get a shoehorn in there for treatment otherwise. And, a patient is going to really appreciate the rapport that develops between you and them. And this, I'm not speaking to you.
No, I think it's important for people to hear this, because you have this perspective that, there's like this good or bad, or, you can't touch this and you can't touch that when you come to someone who specializes in naturopathic medicine. But you're exactly right. Like, the most naturopathic treatment is the one that's going to move the ball in the right direction. So, stability, if you don't have stability, it's hard to get better. So I can relate to, and that's how I practice. I sort of look at like, what's the right medicine for the right situation.
Right. And, I don't know it all. I'll be the first one to tell you that. But I know where I have seen some of my shortcomings and my downfalls, and we're all blind to them. We're continually blind to them until we see them. And I think a lot of mine in the beginning was wanting that pure concept of a pure approach. And if I live in the bubble and all this, and meanwhile, there's mycotoxins in our baby food.
Here we go. Yep. It's like, yeah, exactly. Well, I would love to kind of wrap up with just some closing words, like some take-home messages that you'd like to share, and then just anything you'd like the listeners to know and how people can follow you. We will post all your social links in the description, but if you could kind of just leave us with some closing words.
Yeah. If you're a patient and you're listening to this, again, keep your head up, keep your heart open, surround yourself with people who support you unconditionally. Find a physician that you resonate with. Resonating with a physician is a really important part to healing. And so keep going. What they say, if you're going through hell, keep going. When it comes to other providers or younger providers listening to it, or providers who are isolated and alone in all of this, there is community out there. That's one of the reasons why I became a part of ICI and am now operating as the president of it for the time being. I felt very alone in trying to navigate the world of mold illness. I was looking for a community, and it was just, I never had the warm welcome, And so one of the things that we're really working on driving home with ICI is making sure that we have a community that supports education in the absence of fear of judgment. And so if people are interested in learning more about like environmentally acquired illness or, mold and sick building syndrome and toxins in the indoor built environment, definitely come and check out ICI. And so I'm saying ISEAI, like the ocean, ICI. And I mean, that's what we're there for. That's our goal. And just the phenomenal people who have been involved in ICI and the open-heartedness and willingness to share in that organization has been amazing. And I've been blessed to be involved with it for as long as I have been. So you're not alone if you want to learn more about it, is what I'm getting at.
That's awesome. Well, I am just really proud to be your colleague, and thank you for all that you've done for me, the community, my patients that I've referred to you. So I appreciate you doing this, and I hope to kind of catch up again soon.
Yeah, absolutely. It's always my pleasure, and it's always so good to chat with you again. It means the world to me.
Thank you. Well, take care.
Take care.
Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from that. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing Podcast. And again, much appreciation for you being here with me.